Greetings, I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to the ANA presentation of which surgical approach is best for my acoustic neuroma with our guests from Pacific Neuroscience Institute. Dr. Courtney Volker and Dr. Garni Borkadarian will introduce themselves in just a moment. First, I'd like to handle a few quick items. If you have a question during the presentation and you're watching on Zoom, you can just write that in the Q&A section, which can be found at the bottom of your screen. If you're joining us on Facebook, your questions can be written in the comments section. We may be able to get to have some of those answered as the presentation goes on, but afterwards we'll get to as many as we can. Captions are available for this presentation, so if you're watching on Zoom, you can turn those on at the bottom of your screen. This presentation is being recorded, and you'll be able to find that in our video library on the ANA website at anausa.org. That's also a terrific resource for so many topics related to both AN treatment and post-treatment. And lastly, a reminder to keep your eye on our social media. The ANA is active on Facebook and Instagram and even LinkedIn. Those are terrific ways to learn about the resources available and how you can be more involved with us. Our mission is patient support, so we hope you will access those opportunities. And now, doctors, if you'd like to introduce yourselves, you can get us started.
Well, good afternoon. My name is Courtney Volker, and I am partners with Dr. Borkadarian here at the Pacific Neuroscience Institute in Santa Monica, California, where we've started an acoustic neuroma center. And we're very excited to be a part of this webinar series. And we really want to thank the Acoustic Neuroma Association for inviting us.
Yes, thank you. I'm very grateful for the Acoustic Neuroma Association for all you do for our patients and our caregivers. And we look forward to giving this lecture together, as we do when we're always operating together. So we're so used to that. Thank you.
So I'll go ahead and start sharing my screen. Up here. So again, we are part of the Pacific Neuroscience Institute and in Santa Monica, California. We are one of the only centers on the West Coast that address the acoustic neuroma vestibular schwannomas. And we operate at St. John's Hospital in Santa Monica, and we are happy to assist any patients with answering any of their questions or taking care of their issues. So I know when Dr. Borkadarian and I see patients with acoustic neuromas or otherwise vestibular schwannomas, it's very overwhelming about what decision to be made. And it's overwhelming for the patients to absorb all of the information about their tumor, about the treatment options. And so we thought it would be helpful for patients and their families to have access to this webinar series and sort of walk through once a decision is made to have surgery, what kind of surgical approaches would be best for you. So I thought I'd start out with a little bit of anatomy where we're looking down at the skull base here, and there are 4 nerves that run from the brainstem through the internal acoustic canal out towards the inner ear of the cochlea and the semicircular canals for balance. And acoustic neuromas usually grow on one of the 2 vestibular nerves, the superior vestibular nerve or the inferior vestibular nerve within the canal itself. And then as time goes along, grows towards the brainstem. You can see that this is an intercanalicular tumor. And then as it grows towards the brainstem, looking like an ice cream cone here, this would be like a 1 centimeter tumor and then a 2 centimeter tumor as you start getting some brainstem compression and some midline shift, and then over to a 3 centimeter tumor. The tumor cells originate from the Schwann cells, which are actually the insulating cells of the nerves. And they are a benign growth. So that helps my patients sort of take down the temperature. It is considered a brain tumor, but you can think of it as a growth, a benign growth that grows in this area. So how do we decide if surgery is needed? What parameters do Dr. Barkadarian and I first look at? Well, first we look at the size of the tumor itself. Is this a small tumor, medium-sized tumor, or a large tumor, which we went over before? Is it touching the brainstem? Is it compressing the brainstem? Is it shifting the brainstem? And we usually split the tumors into sort of small and medium size and then larger size tumors. How do we decide if surgery is needed? We secondly look at the patient. So we look at the age of a patient. Is this a very young patient with hopefully many, many decades of life left? Is this a middle-aged patient, an elderly patient, which may have difficulty undergoing risks of anesthesia? So we look at the age, and then we look at other medical conditions. So how healthy is the patient? How much is their body going to be able to withstand the stresses of surgery and general anesthesia? The second group of things we look at are the patient's symptoms. So how is their hearing? Do they have serviceable hearing? Do they have tinnitus, dizziness, imbalance, facial weakness, facial twitching, all of those sorts of things? And so when you focus in on the hearing, is the hearing serviceable? And what we mean by that is a good screening question to ask yourself is, can I understand speech when the volume is turned way up on a telephone when I'm speaking with the ear that has the acoustic neuroma? If the answer is yes, then we consider that pretty much serviceable hearing. And the options for surgery for those patients with a small intercanalicular tumor or a small to medium-sized tumor, sort of the 1 centimeter size, would be either the middle cranial fossa approach or the retrosigmoid approach. And those are our two, what we call hearing preservation surgical approaches. And how do we decide which approach of those two to use? Well, the middle cranial fossa approach is for smaller intercanalicular tumors with good hearing. And we approach that tumor from above the ear. We raise the dura and we come down on the tumor from above. The medium to large size tumors with patients that have good hearing, we use the retrosigmoid approach. Once the tumor comes out of the internal auditory canal and starts looking like this ice cream cone approaching the brainstem, the middle cranial fossa is very difficult. And so we use the retrosigmoid approach to hopefully preserve the hearing. And the retrosigmoid approach, we make an incision behind the ear, or what we call post-auricular incision. Now, what about the medium to large size tumors with poor hearing? Well, two approaches would be the retrosigmoid approach or the translabyrinthine approach. And how we decide on that is really how far out the tumor stretches towards the cochlea. If it's going all the way out towards the cochlea, sometimes the translabyrinthine approach gives us better access to what we call that lateral tumor part. If it's mostly focused around the brainstem, then the retrosigmoid approach is often helpful in those cases. So this is talking about the translabyrinthine approach for medium to large size tumors with patients that have poor hearing. And like the retrosigmoid approach, we make the incision behind the ear post-auricularly as well. And the translabyrinthine approach, we actually go through the labyrinth, so the semicircular canals, in order to approach the tumor. Now, something that's very exciting and may be a game changer in our field is, what about cochlear implants? So cochlear implants are an amazing technology that have been around for years, which is a surgical surgically implanted device that we can actually restore hearing. And we're just starting as a field to think about when we can do a cochlear implant in a patient with an acoustic neuroma. And there are two options. If a patient does not have any serviceable hearing before surgery, then Dr. Barkadarian and I consider doing a translabyrinthine approach, going through the semicircular canals. And if we're able to save the actual structure of the cochlear nerve itself, after we remove the tumor, I can then place a cochlear implant. And I've done that in several patients that have had very great outcomes. They're very happy with their cochlear implant. I've had a few patients where it's actually really helped with their preoperative tinnitus, which has been really difficult for them. And so it's something we're thinking about more and offering more patients. Well, what about after surgery when you tried to save the hearing via the middle cranial fossa approach or the retrosigmoid approach? We do our very best to save the hearing with the best surgical techniques, and sometimes we don't get, we're not able to save the hearing due to blood supply issues, etc. We're starting to think about, are we able to do a second surgery after removing the tumor and place a cochlear implant to try to restore hearing? And this is very exciting. I've done this in a few patients within weeks of the first tumor removal surgery, and I was able to get the electrode in, and they're doing quite well. Talking to other surgeons around the country, they've also tried this, about 6 or 8 weeks out. What we worry about is how long can we wait before the cochlea, due to the first surgery, actually starts to scar and have fibrosis. So that's a future topic that stay tuned to listen for. If you wait too long, then the cochlea is completely filled with scar and you're unable to physically get the electrode into the cochlea. So that's a question that's still unanswered in our field, and we'll have more information and data as time goes on. So now I'm going to hand it over to Dr. Barkadarian, who's going to speak about his portion of the presentation, and then we'll open it up for questions.
Thank you, Dr. Boker. Can you guys hear me okay?
Yes. Mm-hmm.
Excellent. So Dr. Boker did such a great job talking about how we decide on which approaches to take, but I wanted to spend a couple of minutes talking about an important issue that our patients sometimes deal with that can really take a great operation and make it into a significant challenge to patients, and that is the issue of cerebrospinal fluid leakage. And anyone who has had this operation has likely been told that there's a risk of this. And anyone who's dealt with this knows that at the very least, it requires another intervention to deal with. And in some cases, more surgery, and in some rare cases, can become very debilitating for the patient. And so we really focused on trying to figure out what we can do in the operating room to minimize this and really to get that risk, which is, ranges from about 1.5% to up to 15% of operations, down to zero. And what we've done is a combination of tailoring our operation to the patient's tumor size, and at the same time incorporating some reconstruction techniques that help us avoid getting into any postoperative CSF leak issues. There's two mechanisms where fluid can leak out of the area we operated. One is through the incision itself, which requires you to have a watertight closure of not only the covering of the brain, which is called the dura mater, or dura here, but also to have a watertight closure of the scalp and the tissues in that area. But the other mechanism is leaking through the nose. And as Dr. Boker showed, the bone in the area where we drill often has lots of air cells, these mastoid air cells that are in direct communication with the middle ear and are in direct communication with the eustachian tube that drains out the nose. So we are always careful and concerned that if we leave an avenue or a channel for fluid to leak out that way, then the patient can have a postoperative nasal CSF leak, which then requires repair. So what we have done is apply the keyhole technique to our operations. So the idea being that we try to avoid very, very large craniotomies unless we absolutely have to do that. So the vast majority of tumors that we take out through the retrosigmoid approach can be done through a linear incision, like you can see on the bottom right there, as opposed to the larger C-shaped incision. And the opening we make is about 2 by 3 centimeters, so 1 inch by 1.5 inches or so, very small, and yet we can still get to all aspects of the tumor and take the tumor out safely. But because it's a smaller exposure, because we're not wrapping around this curvature of the skull, we're able to reconstruct it a little bit more tightly and allows for a more solid reconstruction. So we also try not to burn the tissue. So we are very much preservationists when it comes to our tissue. So instead of cutting all of the different layers that we have to go through behind the ear to get down there with electrocautery, we just use a blade. And it may take a little bit longer to do in the operating room, but then at the end of the case, those layers come back together perfectly. Whereas when we use the cautery, they tend to shrink and shrivel up, and then you have a big gap there, which is also an issue with that. Is it possible to go to the next axis? Thank you. So what we do is we apply this technique. So not only do we have a smaller exposure, but we thoroughly use bone wax to wax off those air cells that we talked about. And we use a special type of bone wax. It's very soft. We want to make sure that we get out to the little nooks and crannies that would otherwise be missed. We also drill out the little septations that you sometimes see in those air cells you saw in that picture that could be very challenging. So by opening it up, it becomes a little bit easier to do. We try to close the dura in a watertight manner, but you don't need to. In fact, and often we never really achieve that. But what we do is actually take some fat from the belly, just a small incision about the size of 1 inch or so, and we take a reasonable amount of fat, and we overlay that entire area with fat, as you can see in the image on the right. But then we overlay that with a collagen sponge, and then we put either the bone back on, or we put a titanium mesh if the bone was too thinned out with the approach. And then we bring all those layers that we cut through, the muscle, the scalp, the layer below the scalp itself, and pull it all together. So it's a multi-layered closure. So this technique that we've been incorporating really allows us to tailor these operations and then at the same time prevent CSF leaks. The next slide, please. And what we saw in our results is we had no patients with CSF leaks after surgery, or what we call pseudomeningoceles, which are pockets or pools of fluid underneath the scalp that can balloon out and become soft and not very pleasant. It did not affect our average length of stay. We had most patients stayed about 3.5 days for tumors. And some patients actually left the next day or the day after. We had a few patients, about 3% of patients that came back into the hospital, but none returned back for CSF leaks or wound healing problems. They were for other causes. And so you can see that this is a really nice, robust way of reconstructing the area. And we have managed, and this is over a 10-year period, we have managed to have no CSF leaks in all of our patients. And to just put things into perspective, when I was in training, we would have our typical monthly morbidity and mortality conferences, and every month there would be one patient that had a CSF leak. And so we think that this is really something that can be achievable in most, if not all, patients. And I think by using proper technique, tailoring the operation to the patient and the patient's tumor, and to really spending a lot of time on the reconstruction, not kind of rushing through it, and using plenty of fat. We're lipophiles here, so we love fat. Works really well, and I think that'll help prevent these problems, which can otherwise turn a very successful operation to a challenging operation. And I think you can see our team here. It's all about a team approach. There's really no one individual that we rely on, but we have not only our physicians, as you see myself and Dr. Volker, but also our nurse practitioners. Our OR team is amazing, from the neuroanesthesiologists that do a fantastic job taking care of our patients while they're asleep, the OR nurses and the surgical technicians that make sure that the OR runs very smoothly. And then after surgery in the hospital, in the intensive care unit or our step-down unit, the nurses, the physical therapists, the speech therapists, the audiologists, all really making sure that we have a well-oiled machine and taking great care of our patients. Thank you, Courtney.
All right. Is that the end of the presentation? All right. So if you want to stop sharing your screen, that was terrific. That was terrific information. And we have a handful of questions, not surprisingly. You explained all the surgery approaches and the information so well. It's a lot of post-treatment and post-surgical questions that we have. So if you'll both go off mute for a bit, we can get to those. First question is, how often do you see patients who experience dizziness after surgery, and how long does that continue? Is that a common situation after surgery?
So that's a great question. You know, a lot of post-operative surveys have shown that, you know, second to people's worry about facial nerve function, the number 2 worry is dizziness, and the quality of life issues that dizziness and imbalance play to patients getting back out functional, back to work, taking care of their families. And what we have found is that, and I oftentimes test the vestibular function before going to the operating room with physiology results, is if a person's, due to the tumor, if a person has pretty weak vestibular function before the surgery, then when we operate on the tumor, they have very little dizziness after the surgery, because the vestibular function has already been compromised on that side. And surprisingly, those patients actually have a faster recovery. In patients where, and oftentimes smaller tumors, because the smaller tumors have not destroyed the vestibular function as much, when we cut the vestibular nerves to take the tumor out, it's very shocking to the body. And those patients have a lot more vertigo, dizziness, and imbalance right after the surgery. And it can take weeks to a few months for their body, their good side vestibular system, to start compensating. And as torturous as it is when we round on patients, Dr. Barkadarian and I want to get the physical therapist to start working very quickly with the patients, because if you splint your body and you don't want to move, and of course you don't want to move, you're dizzy, it'll take a longer time for your body to recover. Even if you're dizzy, if we get the physical therapist up working with you, walking in the halls, even though you're struggling, then the more data points that you can provide the brainstem, the better vestibular side will have a quicker time compensating and creating the new baseline in the patient. So I oftentimes give vestibular testing ahead of time, not to tell us what we're going to do, not to change our plan, but really to counsel the patient and the family to say, okay, this is what we're going to probably expect post-operatively, and that Dr. Barkadarian and I can have a plan to work with the family and the team.
Okay, so the follow-up question for that's a good segue into that is, do any of the surgical approaches affect dizziness one more than the other?
Dr. Barkadarian, you want to take that one?
Yeah, I mean, I think the main question is really, are we trying to preserve hearing, or are we not preserving hearing? So classically, the translabyrinthine approach, which is really for patients who have no hearing or who have limited hearing that we don't think we'd be able to save, usually for a larger tumor, the vestibular system is completely removed. So actually, that probably has shorter term postoperative dizziness than if we were trying to preserve the tumor or the nerve in a smaller or larger tumor. I think the middle fossa approach, which is really for smaller tumors, it probably has a little bit more postoperative vertigo and dizziness, because we're in a tight area. We are manipulating those nerves. They're a lot more compact, so they get manipulated more, and you probably will have more dizziness after that approach.
Okay. And then do you see, excuse me, do you see migraines as a postoperative issue? And does having migraines, this is a common question, does having migraines before surgery increase the incidence of having them afterwards?
Yeah, so there's postoperative headaches and migraines are somewhat overlapping conditions. They don't necessarily, they're not the same thing, although people tend to use migraines to call them that. But a migraine is typically an intrinsic headache problem with a patient that would have that. Patients who have migraines will likely have exacerbation of their migraines after surgery, and we need to be proactive about it and treat that accordingly. We do everything we can to minimize postoperative pain. In the operating room, we use long-acting anesthetics that stay in the scalp, depending on the type, between 6 hours, but really 24 to 72 hours is what we try to do, so that it's a lot more comfortable. The smaller approaches, so doing a 2.5 centimeter craniotomy versus a 4 or 5 centimeter craniotomy, actually has been proven to decrease postoperative headaches. And the reason is that the muscle needs to reattach. And oftentimes when you remove all that bone, you will have some gaps just by the nature of how it is. And the muscle will attach to the dura or the soft tissue that's in between that area. And then every time you move your head or cough or do anything, that'll pull on the dura, and that will be a mechanism of headaches. So one of the reasons we try to keep our approaches as tailored to the patient's tumor as possible, so it's not as very large when unnecessary, is to prevent this postoperative headache issue that can occur. In some cases, we have to do that, and that's just the nature of the tumor. But when we can avoid doing that, we help doing that.
Okay.
So yeah, less is more in those situations.
Well, continuing on the postoperative issues, we've heard from a few patients about sinus issues after surgery. In some cases, dripping from their nose. Is that common? Is there something that can be done there?
Well, that's what we were talking about in my last portion of the lecture, which is really trying to prevent cerebrospinal fluid leakage. If we can avoid that process, then really you should not have any major drainage from the nose issues. So that we talked about. Now we do enter into the mastoid air cells. Obviously, that's where a lot of the operation occurs, and that is in communication with the eustachian tube that does go to the sinuses. So there can be some inflammation, and some people may feel ear fullness or congestion after surgery, and that can often be overlap with sinus symptoms. But that typically gets better after a few weeks or so. Courtney, what are your thoughts on that?
Yeah, that's a great point, Jim, because I since I'm ear, nose, and throat, I usually ask these questions ahead of time more, but I usually ask my patients about just underlying allergies and sinuses and what their sinuses are at baseline. And if people are really congested and have a lot of allergy and mucus anyway, I have them start doing nasal rinses and get that all cleared out before surgery, because we ask patients not to blow their nose and things like that right after surgery to decrease the risk of CSF leak, as Dr. Barkadarian said. And that's kind of torturous to patients if they already have mucus buildup. Furthermore, I don't want to complicate identifying a CSF leak because people don't know, gosh, is that CSF? Is it just a runny mucus nose? And so I try to proactively have patients, use saline irrigations ahead, a week ahead of time every day to try to clean all that out.
Okay. Well, to wrap up those post issues, we have a question here. It says, which is our surgical approach consistently has the least amount of long-term side effects? Is there anything? I know that must be that's a tough one to answer in general.
Again, I think it comes back down to the tumor itself.
Mm-hmm.
I don't think it's really the approach that can affect what the long-term outcomes are, but it's really the size of the tumor and the patient's presenting symptoms. So if somebody has significant hearing loss or already presents with some facial weakness, I think that has a higher chance of any neurological deficits after surgery versus a patient who has maybe an incidentally discovered or minimally symptomatic tumor, relatively smaller, that will likely have a little bit better set of outcomes. We do everything we can in the operating room and afterwards to prevent some of the what we think are preventable issues that may not be related to the tumor. So CSF leaks, wound healing problems, brain retraction issues that we try to avoid. Those are all things that I think would be a blanket with any of the approaches that we do. So it's really the tumor that can dictate that. Courtney, what do you think?
Yeah, I agree. I mean, we talked a little bit about the size of the craniotomy. Of course, if I am placing a cochlear implant at the time of surgery, I'm going to be placing that under their temporalis muscle, their chewing muscle, which has a little bit of extra pain. But it also, as Dr. Barkadarian mentioned, how they are before surgery. So we know as surgeons, this is across all disciplines of surgery. How a patient does after surgery very much depends on what their condition was before the surgery. So if they're, if they're weak, if they are having a lot of medical problems before surgery or difficulties before surgery, they're going to have that much more difficulty after surgery. If they're really healthy, very fit, not having a lot of problems before surgery, that dictates how they're going to do after surgery. And that's abdominal surgery, cardiac surgery. That's just kind of a gold standard for surgery. And so what I'm really proud of in our program is we have a great support team postoperatively. So we have, we're not a large center. We're a very boutique sort of white glove service that we have great attention to the family and the patients. Every day we have teams rounding. Every day we have great dietitians and physical therapists. And, Dr. Barkadarian and I do our part, but it really does take a team to get that patient recovered and smoothly back to the home.
Absolutely. It's a question here about talking about fatigue. At what point after surgery should you be worried about this? We have a patient who's 10 weeks post-op still suffering from fatigue.
Yeah, I think it's pretty typical to see some fatigue right after surgery. Most of our patients are up eating breakfast the next morning and typically back to normal at about 1 to 2 weeks after surgery. So if I see a patient who is still quite fatigued or very symptomatic, not related to dizziness or any medications, but if they're pretty symptomatic, after the 2 to 3 week mark, I would start looking at other etiologies as to what the fatigue could be. I mean, we always want to think about things like anemia or vitamin deficiencies or any cardiopulmonary issues that could be contributing to that. So those are all things that I would look into for a patient that may see me at that time point.
Okay. Another question is about radiation. Already having radiation and then now needing surgery. Is there a particular surgical approach that's better after radiation, or does that depend on?
That's a very challenging and yet important question because obviously we use radiation for specific tumors, and it does have quite a good success rate. But in some cases, it depends on how long out. But 5 to 10% of patients will still require surgery after radiation, because it does have an efficacy of about 95% or so. So the question really comes down to, what's the best way we can preserve the facial nerve? And that, in my mind, is really the translabyrinthine approach. Many times, patients who've had radiation have already lost their hearing. If hearing preservation is still really critical, then I think a retrosigmoid approach would be ideal. But probably the key thing is we want to identify that facial nerve early and preserve it along the entire length of the nerve, because that usually will become much more adherent to the residual tumor after radiation, and just makes it a lot more challenging. And oftentimes we will not get every last bit of tumor out. We will leave a little carpeting of tumor behind on the nerve to protect the nerve function, knowing that there's still a chance it can grow back, but sparing a facial nerve injury would be ideal.
Mm-hmm. Yeah, that's a great question, because we do see people from all over that have already undergone treatments before. And I always counsel patients that if you've had any intervention before, either surgery or radiation, it's going to make the tumor dissection more challenging. And that's true anywhere in the body, and is true for the area we're operating here. And so I think the tenets that we talked about which approach we would still hold true. Is it a small tumor, a large tumor? Do you have hearing? Do you not have hearing? But I always take extra time to counsel patients that, there is an increased risk of complications after radiation.
Okay. I wanted to circle back to, you had mentioned combining, again, inserting the surgery with the cochlear implant. Who is the best, which patients are the best candidates for something like that?
So some of the best users I've had with acoustic neuromas are those who have had their hearing totally gone on that side due to the tumor. Mm-hmm. And if they've lost their hearing in a relatively shorter time, and that's true even if you don't have an acoustic neuroma, we call it length of deprivation. So if it's been 10 years since you lost your hearing, and the tumor is just sort of slowly marching along in growth, I counsel the patient that they probably won't do as well as a patient that just lost their hearing, within the last 6 months or a year. Now, this is fairly cutting edge in our field to place the implant at the time of tumor removal. So with that said, we're still collecting data as a field, our center, as well as learning from other surgeons across the country at conferences. But I always go back to the neuroscience. I have a PhD in neuroscience. I always go back to what we know about the neurons and what we know about the brain, even in people that don't have a tumor, to counsel folks. So, but with that said, if people are willing to give it a try, it adds very little extra risk of complications. So we're already in the surgical field. We've already done the most invasive parts of removing the tumor, operating around the facial nerve. And so there's no real huge extra additional risks. And so with that said, most patients, I say to them, if you want us to give it a try, if we're able to preserve the cable of the cochlear nerve, the worst case scenario is if they don't like the sound quality, they can always just not wear the magnet. Mm-hmm. And I've never had to take out a cochlear implant after tumor removal, but I always say it's a pretty simple surgery to just go ahead and cut the electrode and remove the internal piece if you don't like it or it's causing pain or anything like that. So most people are interested in learning more and signing up for that. We do run into some insurance problems with that sometimes. And, that's true of anything in medicine when you're kind of pushing the envelope until it becomes more standard of care and we put pressure on the insurance companies. But Dr. Barkadarian and I are always willing to fight. That seems to be part of our job description these days, fight on behalf of the patient. So.
Okay. And now a follow-up to that question. Someone just jumped in and said, is it possible to get the bone anchor placement during acoustic neuroma surgery, or is it better to wait?
So great question. two approaches on that. It's very simple to do, just to place the bone anchored device. Many people may not know what the difference between cochlear implant and bone anchored device, and I probably should have put a slide on that. The bone anchored devices are inserted into the skull. It's very simple, and once the patient heals and the external piece is placed on the skull, the processor will collect sound from the poor hearing side, and through the skull will conduct sound over to the opposite nerve, which is working well. So those are called bone anchored devices. Some patients love their bone anchored device. Some people really don't like it, and it's very easy to remove if they don't. It does not give you directionality of sound, which is one of the major complaints when you don't have any hearing on the one side. Whereas a cochlear implant will actually insert the electrode into the cochlea so that when you receive sound from the poor hearing side, it will go then directly into the brain. So there's no crossover. And then that gives the better chance of directionality of sound. And so that's what's really exciting. But yeah, there's two times that you can place the bone anchored device. You could do it at the time of surgery, or you can wait after the healing process to place the bone anchored device. Sometimes those patients where we place it later are more happy with the bone anchored device because the brain had a chance to say, whoa, I just lost all my hearing. Let me kind of rebalance. And then when I place it a little bit later, they say, oh, wow, I really like that. Whereas if you place it at the same time, sometimes when patients wake up, they say, well, gosh, it wasn't as good as I had before the surgery. And so I just work with the patient and see what they would like to do regarding that.
Okay. And we'll finish up with more of a good patient question specific to a patient here. We have a patient with a 1.1 centimeter tumor, good hearing, and currently watch and wait. And they're wondering when surgery would be considered. They're having a hard time deciding, trying to save hearing and having surgery now, or just continue to watch and wait, potentially have the tumor grow and lose hearing. And they have a fear of, some lifelong effects, mostly facial nerve imbalance issues. I know that might be not enough information, but based on that, what would you?
Yeah, I think that's a challenging and important topic, and it's full of nuances and patient preference and surgeon preference as well. I spend a lot of time sitting down with our patients who have newly diagnosed incidental small vestibular schwannomas about exactly what to do. And we talk about some of the data that's out there for these small incidentally discovered tumors, actually with focusing on hearing preservation, any of the three options, whether you operate, whether you radiate, or whether you watch and wait and then bite the bullet, have about the same level of hearing preservation, which is about 70%. So there's really no wrong answer there. In general, I look at kind of the bigger picture. So if somebody's in their 80s and probably higher risk for surgery, we would often, really encourage us watching and waiting. And if there's any growth, maybe consider radiation to a small tumor. Someone's in their 20s and has preserved hearing, we'll be very, very closely monitoring our patients. So routine MRIs, but even more frequent audiograms. The audiogram is going to be more sensitive than the MRI with regards to hearing. And there's some nuances in the audiogram. Some people just look at the pure tone average, but you also need to look at the speech discrimination and some other factors that Dr. Volker is a lot more expert in than I am. But really close monitoring is really key. And at the first hint of any change in somebody who's young and has a goal or a wish of preserving hearing, then we would offer intervention. I think that's an important other point is, what is a patient's preference for hearing? Some people are avid music listeners or even musicians, or they really rely on binaural hearing. And so hearing preservation is really critical for those types of patients. Other patients, may not really notice if one ear goes, and they'd be perfectly fine with a good other ear. And so, while it may sound shocking right now, but when you really ask patients, what's their goals, some people will say, well, I don't really use my left ear anyway. I'm really right ear dominant, and I use my cell phone on that side, et cetera. So they don't really miss it too much. So they may be more comfortable with a longer term, higher threshold for surgery rather than somebody who really is aiming for hearing preservation. So that's like a 5-minute version of a 30-minute conversation that I have with patients. And I'm sure, Dr. Boker, you probably have similar discussions as well.
Yeah, that's that exact tumor size with good hearing in a young to middle age person is, my heart goes out, because as Dr. Barkadarian said, this is what makes it so challenging. And just walking into the room and throwing a plan at a patient is not going to serve that patient well. And so sitting down and saying, there's no good answer here. I need to know what's important to you. I need to know what your long-term goals are. We're in LA, we take care of a lot of people in the entertainment industry. That person's goal is going to be much different than, my grandmother. And so meeting that person where they are is a big part of doing a good job from our end. Because if you choose the wrong treatment plan for the patient, they're not going to be satisfied or happy with their care. And that means we didn't do a good job either. And so that's what I love about these webinars, is the more that patients can become educated and advocate for quality of life is the best. And the other point I wanted to make is a lot of centers will just treat a tumor. So if a tumor is identified, they will want to intervene. And I know what I really like about Dr. Barkadarian and I is we really, in the small to medium sized tumors, we really wait until the tumor shows us that it's growing or that there's a deterioration of function. Obviously, the larger tumors that are pushing on the brainstem and compression, those need to be taken care of. But those small to medium-sized tumors, the natural history studies show that a lot of those tumors, for reasons we don't understand, just sit there. They really don't grow. And so why treat something that doesn't grow and isn't having any consequences and introducing complication risks to that patient? And, centers do differ on that approach. And so it's important to know that when you're looking at different centers.
Yeah, that decision tree, so many times patients look for, what's the right way to do it? And to your points, it's difficult to say, it's this and this and this, go do this. But of course, finding out what's important to the patient, going into it, especially with their expectations, that's so important to be able to do. So, gosh, well, that's all the questions we have. We really do appreciate your time.
Can I address one other question I saw in the chat?
Oh, sure. Okay.
Somebody asked a question. I think 2 people asked a question about the use of endoscopes.
Oh, okay. I'm sorry. Yep.
Is that okay to go over that?
Sure. Oh, sure. Go ahead. I thought you had covered that earlier. Go right ahead.
So, we use endoscopes for our transcranial operations all the time. It's a very common tool that we use that helps us with various types of tumor types and other pathology. I'm very adept at endoscopy. I've been using it for 10 plus years. And I will say, in my experience with vestibular schwannomas, there's a couple of areas where it's helpful, but for the most part, I haven't found the endoscope to be any more superior than our traditional approaches in tumor section. And the main area that we look at is either in a translabyrinthine or in a retrosigmoid, when we want to look around the corner into the internal auditory canal, where sometimes it could be a bit hidden. That allows us to see any residual tumor that may be left behind, because we can actually bring the light source way down into the area. Or sometimes we'll see some air cells that we couldn't see with the microscope that we need to plug up with fat or bone wax or whatever. And that really helps us out a lot. So I think it's a helpful tool. It's not like a philosophy that you have to have, but it's a nice adjunct to be able to fully take out a tumor or make sure you avoid complications.
Great. Okay, that's a great way to finish up. Dr. Dr. Vogler, Dr. Barkadarian, thank you so much. I will tell you, you've been wonderful partners with us. This was great information. And Pacific Neuroscience, again, has been a terrific partner for the ANA. We really do appreciate it. Thank you for your time today.
We're honored to be on. Thank you.
Thank you.
Thank you, Jim, and thank you to the ANA.
Thanks. Have a great afternoon.